CAS. What's the difference? Cells, individually, they're not aggregated. But if you have a bunch of cells that aggregate, well, clinically, you no longer call them cells. You call them CAS. Are we clear? Now, there are different types of CAS. Now, before I begin, once more, CAS to you clinically means damage to the kidney. Clear? I'm sorry, damage where? To the kidney. CAS. The cells, not so specific. Prime example, I gave you something like neutrophils. Neutrophils could be found with urethritis, cystitis, pyelonephritis. Right? But if you find WBC CAS, then that would be for which diagnosis? Good. Pyelonephritis. So CAS are formed in tubular. What tubular? The urine, the nephron. Lumens in the kidney. Has to be the kidney. They're composed of protein matrix. Now, you've heard of TAM horsefall protein. These are normal components, okay? They're normal components of urine findings. However, there are times when you would find this in settings of excess light chains, Benz-Jones. Maybe something like your multiple myeloma. Now, within the TAM horsefall protein, within which are entrapped cells, debris, or protein leaking through the glomeruli. So whatever it is that is accumulating within the urine, it then combines with your uromodulin or TAM horsefall, and all of this is then going to form a CAS, an aggregate. What kind of aggregates do you want to know? And I'll show you pictures as well. Hyaline cast. Now, this could be part of normal. And then in medicine, in pathology, what we do as well is the fact that you then take these casts that either are cellular or acellular. And as we go through the various casts, we will then take a look at cellular, acellular type of casts. Now, hyaline is a aggregation of protein. And it's ghost-like, which means that when we take a look at this cast of hyaline, which I'll show you, it is very, very translucent, very transparent. Like this invisible little alien in your urine. It's amazing. But it is a cast, though. It's aggregation. Now, no significance, truly, and absence of proteinuria. So you could find this in a patient who's an athlete, who just went for a crazy workout. And you might find hyaline casts because it's just normal damage that might be taking place in which a protein are now aggregating. What's my topic? Casts. Where am I? Kidney specifically. Now, RBC casts. Not RBCs of cells. RBC casts. So we're reading a journal, you're reading a clinical vignette, whatever it may be, you're tired, make sure that you're paying attention. Does that have a cast associated with it or not? If it has a cast associated with it, no doubt kidney damage. What kind of glomerulonephritis is more having or leans towards having these casts? Nephritic. I told you with nephritic. Now, this is the third or fourth time that I've told you to focus on H. Hematuria, hypertension, and with that hematuria, you're going to find RBC casts. Example of nephritic, the most common is IgA. Call it burger, but I would know it as being IgA nephropathy. Another very important one with nephritic would be post-streptococcal glomerulonephritis. WBC casts. Now, you want to be careful here. I'm going to give you two differentials. What did WBC mean to you? Well, we all know what it is. But there are two major types of WBCs that are involved in kidney disease. One would be neutrophils. The other one would be eosinophils. Interesting. So just because you find the WBC cast, the next question you ask yourself, what are these casts made up of? If they're neutrophils, take a look at the differential. We have pyelonephritis, flank pain, urinary tract infection, maybe either hematogenous spread or ascending spread, discussed in micro. If the WBC cast is made up of eosinophils, then this is quote-unquote an allergic reaction. Maybe your patient is allergic to penicillin and has what's known as, these allergies in which the eosinophils causes damage. And this is called tubular interstitial nephritis or acute interstitial nephritis. What kind of casts are these? They're WBC, made up of eosinophils. The other big one, too, clinically, it's called atheremboli with eosinophils as well. Casts. Now we take a look at renal tubular casts. What's this mean to you? Now, here, be careful. Look at the differential. This is acute tubular necrosis. In the previous discussion, what did we see? Acute interstitial nephritis or acute interstitial necrosis. What's the difference? In acute interstitial nephritis or necrosis, the problem is the fact that the patient was maybe allergic to something, a drug perhaps, such as a penicillin or sulfonamide. Once the offending agent has been removed, guess what? You take care of the pathology. Completely different here. With ATN, acute tubular necrosis, who's dying? The tubular epithelial cells are dying. What the definition of a cast? Aggregates of your cells. So the tubular epithelial cells are then dying because they're undergoing, well, what kind of predisposing factor or condition resulted in acute tubular necrosis? Ischemia being the most common. So say that your renal artery is undergoing ischemia due to atherosclerosis. At some point in time with the ischemia taking place, then you're going to cause necrosis to whom? The tubular epithelial cells. What are these tubular epithelial cells going to do? They're going to fall into the urine. They're dying, they're crumbling. And as they crumble, the walls do, they're going to form these renal tubular cell casts. Are these acellular or cellular? Well, these are once again dead cells. They're necrotic. The walls of the nephron are dying. Let's continue. Fatty casts. It contains lipids, cholesterol. You're thinking about what, once again, the concept that I gave you was that when there's decreased protein in your patient, maybe due to nephrotic syndrome, maybe due to cirrhosis, or maybe due to damage to rough endoplasmic reticulum, then you find there to be increase in lipid. Fatty casts, oval fat bodies, found with nephrotic. Example, something like lipoid nephrosis. What's the most common cause of nephrotic syndrome in a child? Minimal change disease. Now we come to a type of acellular casts, and it's known as waxy broad casts. What's this mean? It means that here, the aggregates that you're seeing, which are acellular, are large and they're waxy-like. They're not hyaline. Hyaline was acellular too, wasn't it? And that was an aggregate of proteins. But that would be insignificant in terms of its clinical relevance. Here, however, with waxy broadcast, completely different. Whoa, take a look at your diagnosis. Maybe the sign of chronic renal failure. Refractory. Okay, these are acellular, waxy broadcasts. Put those together.